I'm going to speak to you today about the multidisciplinary approach, not just in surgery, but here at TCH in general. You know, I think we all realize here at Texas Children's now, we are what you would call a quaternary facility. So we're not even a tertiary facility anymore. We expect to get the most complex cases. And so many of those cases require many, many different physicians and providers to evaluate. You know, families do not want to spend 10 days and 10 appointments. They would like to come here and be here for a day or two and then go home with the solution to their problems, with the medicine that they need, or with a plan for the child's care. So in plastic surgery, we have quite an experience with multidisciplinary care. This is the first surgical case that was performed here in Legacy Tower, the tower that arises above us here. We have 6 brand new high acuity operating rooms. This happens to be the primary one that we use for neurologic surgery and craniofacial surgery. So this is the OR that has an MRI in it. We do these procedures with the neurosurgeon, and we have an MRI right there, so we don't have to waste time for the family or for the providers. The child gets the surgery, is scanned in the room, and is right back there on the operating room table with us. We like to bring all the disciplines together, determine the care plan. Any procedures that we can conduct, we'd like to conduct there in the clinic if we can, and then have everybody make sure we're clear with the families about what follow-up they need. You know how disconcerting it is to families to see multiple different providers and have each provider give them a different idea about when they need to come back. So particularly if you're traveling internationally and one surgeon says, well, you need to come back in a month. And then the next surgeon says, well, I also need to see you back in 6 weeks. Next thing you know, they've got 6 plane tickets back for what could be one single visit. So very important, I think, in these situations. Many of our teams contain these providers in them. Realize here in the Department of Surgery at TCH, we have about 140 subspecialty surgeons. We almost have a 1-to-1 ratio for surgeons and surgical PAs. We've gotten so big now that we can't rely on residents anymore. We don't have enough residents to help us. There aren't enough residents in Texas to help us here at Texas Children's. So we rely heavily on our PAs. We always have pediatricians in these teams, nurses, the therapists. Many have audiologists and speech therapists, particularly around our craniofacial surgery. Geneticists are very common, as you know here. Of course, the parents, we feel, are included in every step. And I think that's very important and gets to what Dr. Suresh was saying earlier. The families need to feel that they are part of this care, that they are sharing in the decision making. And so anytime we set up a multidisciplinary clinic, it involves bringing the family into the discussion about what they expect to be done. Families don't like to be told to do things. Matter of fact, the #1 phrase that is used in family complaints that we see here at Texas Children's is, "They told me." They told me. Patients don't like that. These are a list of all of the multidisciplinary clinics that we are associated with in surgery here at Texas Children's. Bariatric surgery, cerebral palsy, cleft lip and palate, one of our oldest clinics here, colorectal and pelvic health, complex airway clinic, craniofacial clinic, epilepsy clinic, fetal surgery clinic, gender medicine, which is a new clinic for us, head and neck tumor clinic that for the first time MD Anderson participates in. MD Anderson has started bringing the smallest babies with head and neck cancer over here for surgery. They don't feel comfortable doing that anymore at MD Anderson on the smallest children. So they will send over their ENT surgeons to operate on the children here, and our plastic and craniofacial surgery team will reconstruct the children here. Spina bifida, spine surgery, which is a very, very big program now that we've actually expanded to the other campuses. The demand is so great. Transplant, of course, and vascular anomalies. I want to give you an example of why these multidisciplinary clinics are so important. In no small part, it's because of the timeline involved in so many of these children. You know, our interventions are not just one and done in many cases. That's the most complex thing really about surgery in children. It's the fourth dimension. They grow and they need other interventions as they grow. This is a classic timeline for cleft lip and palate patients. And you can see here on the top the treatments and the therapy that are recommended. It goes from a prenatal conversation, and increasingly we're seeing these kids while they're still in utero, in referral from the OBs, up to 18 years of age, when typically we're performing their last surgery. When you think about how you design a multidisciplinary clinic visit, there are two ways you can do this. One, you can have the patient in a day go from room to room to room to room to room, or the patient-centric way is to have the patient in one room, and the providers go in and out of that one room with a coordinator coordinating the flow of providers, much like an air traffic controller. So when you have 6 or 7 different providers in one clinic, it's very important that we have somebody who knows who's available when, because you need to pull somebody out of this room, into this room, and out of that room, into that room. So in many ways, this looks like a landing strip in these busy clinics here. But the families appreciate not having to move around all the time. This is an example of a specific program here, our craniosynostosis, or our craniofacial clinic. You can imagine the amount of coordination that is required. So at the end of the visit, the family gets one summary from us about what happened that day and the recommendations. They don't get 15 different notes. They get one note from us about what happened that day. And the referring physician gets that note. I think a case we did a couple of years back exemplifies our multidisciplinary approach to care, the Mata twins. These were conjoined twins that were referred here prior to birth. These children were conjoined from the very top of the sternum all the way through and including the pelvis and the perineum. So everything was hooked up. The heart, the lungs, the sternum, the intestinal tract, the ureters, the pelvis itself. If you don't really have a multidisciplinary approach, there's no way you can get these two babies apart alive. This particular operation took almost exactly 24 hours. It took almost exactly 24 hours. There were 13 specialties involved, 12 separate surgeons, 6 anesthesiologists, and multiple nurses. We involved the specialties of plastic surgery, pediatric surgery, our liver transplant surgeons, CV surgeons, urologists, orthopedics, and our adolescent gynecologists here. I just cut to the chase, but these are the kids in a fairly recent visit, both doing well. One still has underdeveloped lungs, and that's something that we've come to find out with a lot of these conjoined twins. The lungs are an issue, and usually one twin does much better from a pulmonary standpoint than the other, just because of the fetal circulation and the way it was. The decision for surgery is a big part of a multidisciplinary visit, because as you might imagine, there are different risks with different aspects of a procedure. And I, as a plastic surgeon, am not really good informing a family about what the cardiac risk of that is. So it's very important to have all the providers in a room sitting down with the family and having them each go through their portion of the procedure with the family and say, do you have any questions? Invariably, as you know, when you consent a family, 2 providers down the line, they remember a question they want to ask that provider, and you end up going back. So this is a very long process to really inform a family about this, because in point of fact, these conjoined twins don't have to be separated. They don't have to be separated. And the worst thing for a family is to make this difficult decision and then to lose one or both of their children in the process. Increasingly, in our complex surgeries here, we have extensive pre-surgical planning. In craniofacial surgery, and a lot of our neurosurgery now, this involves computer simulations, taking plans, overlying normal images, and moving bone or tissues around to determine what the ultimate result is supposed to look like. And even these days, we've started designing cutting templates. So for the skull, based upon the plan, we'll create essentially a helmet for the skull. And at the time of surgery, when we've exposed the skull, we just stick it on, and it's got like dotted lines, and it shows us where to cut. It tremendously increases the accuracy of the procedure. In things in the trunk, more and more we're using computer-assisted modeling. So we will actually get these models and manipulate them. And it's amazing how much better prepared you are in many cases when you have it in front of you and you can see in 3 dimensions what you're trying to achieve. Certainly, that's very important in something like these conjoined twins. Again, the planning is complex with all the specialties. Many of these procedures really require that we have the radiologist there with us to help us interpret a lot of the images. And we more and more and more are simulating what we do. I wasn't always a big fan of this. I thought I could probably do everything in the operating room. But it's amazing how much you learn when you get in the environment with everybody around you and you put 2 little attached mannequins of babies on the table and you start going through the procedure. A lot of little things you didn't think about, like when you finally separate them, how do you get the other bed in there and actually move it to the other room? How do you put in the airways in these children? Because they're facing one another. In these 2 cases, they're facing one another. How do you intubate the children? How do you get their lines? What do you do about their lines when they're finally separated? Because at one point they're sharing a circulation, at the next point they're not. But you can see everybody standing around the table just discussing it. You know, so if I do this, how does it affect that? And a lot of things about readiness. It's not just us, it's nursing, it's the therapists. So if you see here, to start this case with conjoined twins, we had to put in tissue expanders. That's very common with conjoined twins. You don't have enough skin to cover things. But as you put in a big tissue expander on either side of these conjoined twins and you inflate it up, you end up with about 20 pounds of saline on either side of a kid. Well, you can't just throw them back in a crib when they're like that. So we had to have our biomedical people work with our nurses and our therapists to design an upright crib/chair like this, so the kids spent their entire time in this upright chair looking at one another. And the surgery itself, really fascinating. You know, getting an early start in the day, which is always important here, getting the kids to sleep and getting going, and making sure we had the providers on hand when they were ready. This was a very difficult surgery, I will say, and one of the children, in the process of separating the hearts, coded. Fortunately, the chests were open, so we gave open cardiac massage, and she suffered no sequelae. But it was a very, very difficult surgery by any stretch. This is an example of the room during the procedure. These are our old, large operating rooms. And you can see, there's a lot of equipment here. It's very crowded. Here's our rooms now, and you can see it's about as big as a football field. You can fit almost anything you want in that room and get the unnecessary equipment off to the side while still having room for people to wander around the table and get the procedure done. And of course, the post-op care, having the ICU spaces that are necessary for these families. I know I keep bragging on Legacy Tower here, but you realize these are the largest ICU rooms in the country now, if not the world. Our largest rooms here are about 3 times the size of our previous ICU spaces. The families designed these with us. We started the entire construction and design of Legacy Tower by getting the families together. Our family advisory group consisted of families all who had had children who had been here, in some cases for months. In some cases, the families' children had died here. They were very firm in what they felt they needed. And you know, the number one thing they all felt we had to have in each and every private room, bathroom, and shower. So every room here has a bathroom, full shower, and space for the family to work while they live with their children while they're in the process of getting better. But we're very proud of that, and the families really do love it. Therapy is always important in so many of these children and kids, and the long-term follow-up. These kids are up and walking now, but here's a little update for you.
Say hi. Say hi.
problem. Thanks so much for your time and attention, but that's how we do multidisciplinary care here at Texas Children's. I appreciate it. Thanks, guys.